Good evening. It's Jo here from Starjumpz with Olivia and Georgie. We're going to start the presentation on hypermobility and neurodiversity, understanding the connection. We'll start shortly. If you've got questions, please add them in the comments on Facebook and we'll address them at the end. We'll just give a moment or two for people to join us, and we'll be starting very, very soon. We're just 1 minute past 7:30. Just give it a couple of seconds more. So I think we'll begin. My name is Jo Brett. I'm CEO and occupational therapist at Starjumpz, and I'm here this evening with Dr Georgie Siggers, who's at the bottom of your screen, who is consultant neurodevelopmental paediatrician, and here's a little bit about Georgie.
Good evening, everyone.
Georgie, I don't know if you want to make any comments on your experience and your interest in this subject before we start.
No, I mean, other than I'm just very obviously passionate about assessing a child as a whole child rather than focusing on diagnosis, and I think that, you know, this is a good topic to show why I think that's so important.
Thank you, Georgie. And we also have in the middle of your screen Olivia Luke, who is the lead specialist occupational therapist at Starjumpz. Olivia, likewise, would you like to make any comment?
Hi, everyone. It's just lovely to be here. And I also look forward to sharing what we so passionately love, and specifically about this topic and how it impacts the whole child.
Thank you. Okay, Georgie.
Thank you, Jo. Yeah, so just to cover the learning objectives, hopefully you'll come away from this evening's presentation really appreciating that hypermobility is far more than bendy joints, and we're going to be talking a lot about the sort of hidden impact of hypermobility, but its impact not just on motor function, but also on the gut, the brain, and our regulatory systems, and the link with neurodiversity, and understand the role of occupational therapy in supporting children and young people with hypermobility, and hopefully come away with some practical strategies as well to support children impacted. Next slide, please. Yes, so what is hypermobility? I think that many people will think that it means bendy joints. Next slide, please. And what I really want to stress is it's so much more than that. So if we think of a simple analogy of a house, and the bones, muscles and organs are the bricks, then the mortar that keeps it all together is the connective tissue. So that is collagen and fascia. And if that is softer than it is expected to be, the house doesn't collapse, but there is a lot more movement, less stability, greater strain, and increased need for compensation. And so actually everything has to work a little bit harder and experiences more wear and tear over time. And that is really what hypermobility is. So it's not just about being double jointed or having flexible joints or super elastic as the terms that we might use with children, but it's a difference in the connective tissue that can impact many systems in the body. So if we appreciate that connective tissue is everywhere in us, it's not a surprise that the impact extends far beyond the joints. So next slide, please. And the classification or terminology is quite confusing and has changed over the years. So years ago, you'd see the term benign joint hypermobility syndrome, and that I think has really sort of underplayed how significant hypermobility can be for many people, because it implied that it was nothing to worry about. But then at the other end of the spectrum, we had these different types of Ehlers-Danlos syndrome, but they would be very specific criteria that had to be met. So a lot of people would be stuck in the middle without really the significance of their hypermobility actually being identified. So in 2017, there was a reclassification, and hypermobility is now basically viewed as a spectrum. And at one end of the spectrum, you have generalized joint hypermobility, which is the bendy joints, but without other symptoms or impact, arguably. And then in the middle, you have the hypermobility spectrum disorder. So this is where the hypermobility is causing a clinical issue. So there are associated symptoms and it's having an impact on daily life and function. And then at the other end of the spectrum, you have a much more complex situation, now classified as hypermobile Ehlers-Danlos syndrome. And there are additional diagnostic criteria there and broader connective tissue involvement. And some of the conditions that sit within that group are actually very serious and have a very significant impact. But what's very important to remember is it's not just about how bendy somebody is. So the sort of more bendy you are doesn't mean the more significantly you are impacted, but it is about the collection of symptoms that are occurring, and whether they are affecting somebody's daily function and therefore impacting on their day-to-day life. So next slide, please. So this just highlights how complicated it actually is. So the outer ring of that circle, we have the joint hypermobility, so the asymptomatic, so that would be the mildest end of the spectrum. And then in the middle, we have the hypermobile Ehlers-Danlos syndromes, and there are actually 13 of those. And so, I mean, some of them are more common than others, but they are very significant and have a severe impact. And then in the middle, we have the hypermobility spectrum disorders, and they're also subcategorized. So you can have a historical, so appreciating that as we get older, we just generally we lose some flexibility in our joints, but you can have localized, peripheral, generalized hypermobile. So it's quite complicated. So if we move on to the next slide, please. And important to say that actually most children would fall into that middle group. Most of the children that we see associated with neurodiversity would fall into what we call the hypermobility spectrum disorder group. Some will fall into the hypermobile Ehlers-Danlos syndrome group. But really important that we appreciate that even actually, I think for some of the children that we see who have the asymptomatic joint hypermobility, combined with their neurodiversity, can have a significant impact on their day-to-day life. So how do we decide if somebody is clinically affected? So I think the common word that people will hear is the Baton score, and that is basically a test of your joint flexibility, and you get a score for each of the items that you can demonstrate, and there is just some examples there, but I think the classic thing that we see would be the hyperextensible elbows, knees, being able to bend your thumb right back, being able to lean forward with your knees without bending your knees and touch the floor with the palms of your hands. And so each one of those things gets a score, and typically for young children we would be looking at a score of 6 or more to be significant. But it's not just based on the score, and some people would argue that actually even one score is showing that you have hypermobility somewhere. So if that score happens to be, for example, in your hands, that could have an impact on your handwriting. So it's really important that we don't sort of fixate too much on the score, and that we're recognizing it rather than not recognizing it. But to diagnose a hypermobility spectrum disorder, you also have to take into account family history, symptoms such as pain, fatigue, recurrent injuries, skin features, so increased skin elasticity, poor wound healing, easy bruising, and then other symptoms, which we're going to talk a lot more about later, but such as the dysautonomia and functional difficulties. Now, I think this is really difficult in our neurodiverse population of children because many of them will be experiencing fatigue, which might be related to the fact that it is actually hard work to live with an autistic ADHD brain, for example, and go to school, but it could be that that's also related to their hypermobility or exaggerated because of hypermobility. So, unfortunately, there's no like distinct tests. There are blood tests you have to do in the to ascertain whether you fall into the more serious Ehlers-Danlos syndrome group, because many of those will have genetic markers, but actually in terms of the hypermobile spectrum, there's no single blood test or single sort of diagnostic point. But it's very important that there is a good clinical history and examination. So next slide, please. And so how common is it? It's actually very common, but I would say particularly common in our line of work, and something I've been increasingly aware of over the last 10 years, seeing children at Starjumpz. But depending on age, in the general population, about 1 in 10 children will have what we would consider generalized joint hypermobility, and most of those children would never it's not having an impact, they're not requiring any medical attention. But a smaller group will have associated symptoms that have an impact on daily life, and that's the group that we're clinically interested in. And then when we think about the group that are also neurodiverse, adds particular risks and challenges. But the Ehlers-Danlos hypermobile group is obviously, as you can see from this slide, actually rare, but we would occasionally see children that we would suspect would fall into that group. So next slide, please. And so over the last decade, I think we've become more and more aware of the link between hypermobility and neurodiversity, and the exact percentages do depend on what study you look at, but they would range anywhere between 30 and 60% of autistic people being hypermobile, and anywhere between 20 and 50% of people with ADHD being hypermobile. So significantly more common than in the general population. And there's consistent data that shows that there is a link. Next slide, please. And this is the findings of an audit just very recently completed by one of our neurodevelopmental practitioners, Holly, and she looked at 181 neurodevelopmental assessments and looked for whether it had been recorded that the child either had an existing diagnosis of hypermobility or hypermobility had been identified at the time of the assessment. And she found that 100 out of the 181 were considered to be hypermobile, so a very high percentage. And then she's looked further to see, well, what else has that been associated with? And one of the things that people who know me will know that I'm particularly interested in is burnout. And actually, out of the hypermobile group, 34% of them were presenting with features of autistic burnout. And this is at their first appointment or first assessment at Starjumpz. So that's very significant compared to 20% in the non-hypermobile group. And 87% anxiety. And that's interesting because, as I talk a little bit later, anxiety is strongly linked with hypermobility as well. And then there were 42% of the hypermobile group who were suspected to have or had a diagnosis of developmental coordination disorder or dyspraxia. So I'm going to come on to why I think it's particularly relevant, this data, in terms of risks for young people who are neurodiverse, a little bit later. But next slide, please. But the question is, why is there this link? Is there a reason for it? And the answer is we don't know exactly, but there's lots of different models and theories that are being looked at. One of them is it a shared genetic or biological pathway? Some people are looking at or actually putting the hypothesis that maybe there is a sort of secondary autism, ADHD condition that is sort of effectively not caused by hypermobility, but is there in the link? Is it that, and I'm going to talk a little bit later on about the differences that we're now discovering in the brain when you're hypermobile, is it because of those differences and the way that you perceive the world in terms of your sensory experience and your emotional regulation, that is some share, that has some kind of link? We just don't know. But there must be a reason, because it's such a strong association, and lots of different theories are being looked at. But important thing, it's not one causing the other, but there's some kind of shared cause. And next slide, please. And so what are the impacts of hypermobility? Well, just as we've said at the beginning, the hypermobility can affect our whole body. The impact is wide-ranging as well. So Olivia is going to speak in detail in just a moment about the impact on movement and balance and interoception. But important to remember that there are also, because we have connective tissue everywhere in our body, has impacts everywhere. So impacts on the nervous system, and I'm going to talk a little bit more after Olivia has spoken about the motor impact, on the impact in the brain and what we're discovering, on the gut. So many children who are hypermobile will have associated gut symptoms, but also on general brain functioning, cognition and emotional well-being. And then there are other associated impacts, so on wound healing, on skin, on dental health, on the jaw, so wide-ranging impacts. And what's interesting but also very sad is that when studies that have looked at adults who are hypermobile, who have many of these impacts in their whole body, it takes many years for people to actually work out the connection, and in that time they've really suffered significantly, and sometimes have been mislabeled or have not been believed because their symptoms have seemed so random, and people have missed that there is something connecting all of this. So that's what's so important, that we know more about this, and we're better at understanding it and recognizing it. So now I'm going to hand over to Olivia, who's going to talk about the motor side of things.
Thank you, Georgie. Appreciate that. So Georgie has wonderfully explained quite intricately how it's defined and where it originates. I'm going to be looking at how it impacts a gross and fine motor level, as well as how an interoception component, how that interplays in a child's life. So I'm going to start with an example of a child. So this is Ella. She's an 8-year-old who is bright and sociable. She loves reading, but she finds writing quite difficult, and increasingly so as the demands for writing increase. After about 5 or 10 minutes or so, she complains that her hands hurt, her handwriting starts to become messy or deteriorates quite quickly. She avoids things like PE, saying that she's just not sporty. She often sits out at playtime because she gets tired. And parents report that she has frequent trips and falls, and teachers also notice that she leans over on her desk and constantly changes her posture when she's sitting. So initially, these behaviors were interpreted as poor motivation or possibly a lack of effort, sometimes even lazy. So from an OT perspective, these are all functional clues suggesting that the underlying issue isn't motivation, it's body stability, it's fatigue, and it's reduced efficiency of movement. So by the end of today's talk, we'll understand why Ella presents like this and ways that we can help her. So as Georgie has explained what hypermobility is, I'm going to look on the gross and fine motor aspects. And we'll also explore a bit about assessment and how OT can perhaps help with the intervention approaches. And hopefully we'll leave you with some practical support and ideas to help your child. So hypermobility simply, as Georgie was saying, simply means joints moving beyond the expected range. Many children are hypermobile and actually never experience any symptoms. So for others, however, increased joint mobility leads to instability rather than flexibility. So when joints are unstable, muscles have to work much harder, and they have to work harder simply just to maintain the posture and control movements. This increases their fatigue, and it reduces movement efficiency and can contribute to their pain. So another important point is that hypermobility isn't just about the joints. Increasing evidence suggests that many individuals also experience differences in proprioception, which is your awareness of your body in space, as well as interoception, which I'll discuss a little bit later. So as occupational therapists, our focus isn't on the diagnosis itself, but we are interested in how the hypermobility affects occupational performance and basically what your child needs and wants to do on a daily basis. So the link with interoception is basically interoception means to your awareness of noticing, interpreting your body signals that are coming from inside the body. This may include things like hunger, thirst, fatigue, body temperature, your muscle efforts. For many children with hypermobility, these signals can be less clear and harder to interpret. So rather than recognizing they're becoming tired, they may continue working until they suddenly hit a wall, and then they're quite emotionally overwhelmed by this. So others may experience discomfort but struggle to identify exactly what they're feeling. This can have a significant impact on their emotional regulation as well as their motor performance. So if a child doesn't recognize they're becoming physically fatigued, they can't pace themselves effectively during the day. And as OTs, we often work on developing their body awareness through regular check-ins, energy scales, movement breaks, helping children identify what different body sensations feel like and what they mean. So improving interoception can help children become much more, it can help them better manage their own participation and how they're doing. So why are motor skills affected? I often explain this to parents as a domino effect. So if joints are less stable, muscles have to provide more of the stability that the ligaments would normally provide. That increased muscular effort means that the body uses more energy just to complete everyday tasks. So poor proprioception and the feedback also means that the brain receives less accurate information about their body position, so the movement becomes less efficient. Children may also experience pain or discomfort, leading them to adopt compensatory movement patterns, which then lead to additional problems. On top of that, if interoception is reduced, they may not notice the early signs of fatigue until they suddenly reach a point where they can no longer cope. This combination explains why motor tasks often appear inconsistent. So the impact on gross motor skills. Gross motor activities require continuous postural control and stability. Children with hypermobility often demonstrate poorer balance, reduced coordination, and lower endurance. They may appear clumsy, they trip more frequently, or they avoid activities such as cycling, PE, or sport. One thing I always emphasize is that many of these children aren't weak. They're working much harder than their peers just to achieve the same movement. So that increased effort often leads to fatigue, reduced confidence, and avoidance of the physical activities. So in clinic, we often notice characteristic movement patterns. Children may W sit, because this increases their stability. They often lean against furniture or rest on their tables, and they struggle to maintain an upright posture. You may notice that they have locked knees or elbows, they have joint hyperextension, or they're constantly shifting their position while they're sitting. Teachers sometimes describe these children as fidgety or lazy. In reality, they're continually trying to find a more stable or less fatiguing position. The same principles apply to fine motor skills. Small muscles of the hand have to compensate for reduced joint mobility and stability. Children often grip pencils with excessive force to create the stability. Others have weak endurance and struggle to maintain handwriting over a long period of time. They may complain of sore hands, work slowly, or even avoid fine motor activities altogether. Reduced proprioception also affects the force of grading, so they may press too hard or too lightly during the tasks. In school, handwriting is often where difficulties become the most obvious. Children may begin neatly with their handwriting, but it often deteriorates quite quickly, and as their fatigue increases, so their handwriting gets worse. They may constantly reposition themselves, lean on the desk, or change their grip. Some children don't even notice that they're becoming tired until their work quality just suddenly declines and nobody can read what they've written. These difficulties can have a significant emotional impact, affecting their confidence, their self-esteem, and their willingness to participate. So occupational therapy assessment looks well beyond the joint range. We're interested in participation. We assess posture, proximal stability, coordination, endurance, fatigue, sensory processing, and increasingly interoceptive awareness. I also spend a lot of time observing how children approach tasks, how they pace themselves, how they respond to challenge, and whether they recognize when their bodies need a break. This holistic picture guides intervention. I've listed some of the assessment tools that we use at Starjumpz to get a real comprehensive assessment, which brings about most of their functional issues. Our interventions are always functional. We don't simply strengthen muscles, we help children participate more successfully in everyday life. These might include improving proximal stability, providing proprioceptive inputs, adapting classrooms, their seating, recommending pencil grips or slanted board. Equally important are the interoceptive strategies. Teaching children to notice their body signals, recognize fatigue early, and use the planned movement breaks can dramatically improve their endurance and their participation. Small environmental adaptations often make a surprisingly large difference. So the key takeaways that I want you to take home from an OT side is that hypermobility is much more than increased flexibility. Motor difficulties often arise because the body is working much harder to achieve stability. Fatigue and altered body awareness, including interoception, are major contributors to functional difficulties. Occupational therapy focuses on enabling participation rather than simply improving movement. And finally, understanding why these children move and behave as they do helps us replace assumptions of laziness or poor motivation with empathy and effective support. Okay, so I'm handing back over to Georgie, who will now be discussing the Bendy Brain.
Thank you, Olivia. Yes, so the Bendy Brain. Dr. Jessica Eccles, or otherwise known as Dr. Bendy Brain, is a consultant neurodevelopmental psychiatrist working with adults at Brighton Medical School. And she's internationally recognised as one of the leading researchers in this field, and she's and her team have established the links between hypermobility, neurodivergence, autonomic dysfunction, and mental health. And she has a podcast, but also YouTube videos with lots of a series of videos around the brain differences, and they're really fascinating. So if you're interested in that, you can easily find her if you Google her. But she's done some amazing work that's helped us to understand more about the links with the brain. Her team have done MRI scans of brains and found that people who are hypermobile have some structural differences in areas of the brain that are involved in processing emotions and internal body signals, so interoception. So it can immediately help us to understand a little bit more about more of the wide-ranging impacts. So this has been particularly relevant for me in trying to understand more the anxiety that so many of the children that I see who are autistic, and particularly who are autistic and ADHD, experience, that they can't really explain, but is a very, very real, and it's often a fear, and it's usually related to school. Actually, if we can understand more about how their brains are processing the environment and understand how that might be so heightened, it can really help us to understand why for some children, even an environment that is considered safe by other children might be being perceived as really unsafe for them. So Dr. Eccles and her team, they have identified differences in regions of the brain called the amygdala and the insula. And the amygdala is a fascinating area of our brain that is our sort of threat detection center, but also the way where we process emotions. And so we can now sort of, if we understand that there's a difference in how that's put together, it helps us to understand more about why children seem to be so much more sensitive to threat, some of these children. I think what's important to state is that I can see this type of anxiety in autistic ADHD children who are not hypermobile, but it does seem to be more intense in children who are hypermobile. And also because many of the children that I'm seeing who are autistic ADHD are also hypermobile, but they're not mutually exclusive, and there's lots of overlapping features, things that ADHD can cause an impact to, as well as hypermobility. So it can be quite difficult to sometimes tease out what is the driver, but I think just so important that we recognize the drivers and however they're contributing. But the amygdala is particularly involved in that threat detection and fear processing. The insula is more involved in interoception. So that's interesting in terms of, for some children, I really get the sense that their brains are like overly sensitive to changes in heart rate. But as we'll get onto later when we talk about dysautonomia, there can be some real difficulties in how that's regulated, and a lot of these things kind of then reinforce to the brain there's something to be really scared of. And many of the children, and as Olivia's alluded to, they don't necessarily recognize these feelings. So, and then even if they do, they may, because of the way that their communication challenges impact them, think that other people know already that that's what they're experiencing, or they may find it really difficult to explain to their parents what it is that they're experiencing. And I thought it'd be quite helpful to just think for a moment about what that might feel like, because it is really complicated. But we have most of us will have quite a strong link between our body and our brain, and our body telling our brain or giving our brain signals about how we're feeling. So as Olivia's covered, that could be I'm tired, I'm thirsty, I'm hungry, but it will also be in terms of emotions. This is a situation that I'm feeling quite nervous or frightened about, or this is something that's making me feel angry about. And we get those signals as well as all the time whilst we're doing other things. And for most people, or a lot of people, they're quite quiet signals, but they're very clear, and we get our brains can process them in a very logical way, and it will tell us exactly how we're feeling. But in hypermobility, what we're understanding is that those signals can be louder, they can be variable, and sometimes they're not accurate. So the body is sending quite a confusing message at times to the brain, and the brain has to then work much harder to interpret that. And then over time, because of then how that leads to an emotional response, this is a really big load and kind of extra drain on a child's brain battery. And I think another reason why so many of these children become so exhausted, not just because of the extra effort that they're having to put in to overcome the physical motor challenges. So if we can just move on to the next slide. And so there are actually lots of different things that we're starting to recognize can happen in the brain for hypermobile children. And this is something that has been demonstrated, and in adults as well, in general populations of children and adults, not specifically autistic ADHD children. But when we then think about the added impact that that will bring, it becomes quite overwhelming actually to think about what they're having to overcome just day to day. But if we look at brain fog, so many children they may not necessarily say this, but parents will see that there's a change. You know, there can be a real variation in how alert they are. Sometimes children will be able to recognize that their brain feels fuzzy. It's obviously difficult because many of these symptoms would be the same as ADHD, but struggling to concentrate, find their words, remember information, process what they've heard. But sometimes you'll get a story from a parent that their child's functioning will vary day to day, and some days they may be sharper, more alert. And what we're starting to understand is that brain fog is often worse after periods of intense physical activity, poor sleep, demanding school day. So there's a link somehow to fatigue and our autonomic function that we've not previously identified. But if you add brain fog to the challenges that day to day you're experiencing with ADHD, you can see why the two together could be even more significant in terms of impact. Then some of the research is suggesting that children with hypermobility, because of these structural differences in the brain, may have greater emotional reactivity. So again, this is something that I would typically see in a child who's autistic ADHD, where there's more intense emotional reactivity, becoming more overwhelmed more quickly, taking longer to recover after stress, and then a lower threshold before they reach that emotional overload. But hypermobility is adding to that. And we think this is because the nervous system is processing those internal signals slightly differently. So meaning that the emotions can genuinely feel bigger and harder to regulate. And then I know Olivia's covered interoception, but actually it's important to think a little bit more about that in terms of the brain. Interoception is also involved in our bodies knowing if we are stressed, fatigued, tired, nervous. So there are differences there that then mean that you could be at risk of being in a situation for longer than is good for you, because you've not recognized the signals, or you're not getting a clear signal to tell you that. So we'll often see that sort of child keeps going, and then they suddenly run out of batteries and are exhausted. And then the next area is autonomic load. And I'm going to talk a little bit more about the autonomic system in a moment. But the autonomic nervous system is what is keeping our blood pressure, heart rate, digestion, and temperature stable, and giving signals to when we need to make an alteration, or consciously or subconsciously. And so if that system isn't working efficiently, the body is having to work much harder to adjust. And so, of course, that will be taking more effort and energy, and having more then of an impact on a child's day-to-day functioning. And then finally, Dr. Eccles has done some amazing research looking at anxiety and low mood, and found there's some very convincing data showing that people who are hypermobile are far more likely to experience anxiety. There was a particular study that she's done recently looking at teenagers, and their risk of chronic fatigue is increased if they're hypermobile, and their risk of developing an anxiety disorder, and that's not accounting for them if they're neurodiverse. And obviously we know that that adds to the risk as well. So I think the risk is very significant if you're neurodiverse and hypermobile. So, and that's thought to be, sorry, just go back as that, thank you. And that's thought to be related to emotional processing, autonomic regulation and interoception, but it's also linked to lived experience. So many of the children and young people that we see will be living with chronic pain, fatigue, unpredictable symptoms. They will be aware sometimes that their body just seems to be reacting in a slightly different way to maybe some of their peers, and they don't understand why. And then for some, these symptoms may not be sort of understood or believed. So there's also the impact that that lived experience has on confidence and well-being. So I think really important to remember from this, if we add now what we're recognizing is happening in the brains of people who are hypermobile to the differences when you're autistic and or ADHD, it can help us to understand even more why day-to-day life and particularly school is so exhausting and overwhelming. So then next slide. Thank you. And then I think an area that we often overlook, particularly in our line of work with neurodevelopmental assessments, is the gut. And yet we know that children, particularly autistic children, are far more at risk of having gut symptoms. And there are established links, but actually hypermobility has a very significant link with gut difficulties. So connective tissue is obviously found throughout the gut and is responsible for lots of the gut movement and regulation. And so if that is put together differently, you can start to understand why there can be differences in the way the gut is functioning. And then when you add the impact of the nervous system, which is the way it's also responsible for digestion and all of those clever processes that are going on, we can understand more about why hypermobile children can more at risk of gut issues. One of the things that can happen is they can get gut dysmotility. So if the connective tissue is more elastic than usual, or the nerves controlling the gut are not working quite as effectively or efficiently as they're designed to, then the movement through the bowel can either speed up or slow down. So that means that you might get constipation, you might get diarrhea, you might get bloating. That will be if your gut is contracting too fast, you might get abdominal pain, you might feel sick. So a lot of children will get IBS-like symptoms. And sometimes we can be quite quick to just say that that is, probably anxiety related, when there may be something, and there will be an impact, but it's probably not just that. Then we're also increasingly aware of what we call visceral hypersensitivity. So the actual organs themselves can be extra sensitive. And I think I definitely get a sense that for quite a large proportion of the children that I see, there is something around their gut sensitivity. So it's not uncommon for children to report that they can actually feel the food when it gets to their stomach, and it makes them, in the way that many people, I guess, would feel full after a big meal. They could feel that sensation very early on into a meal, but it's actually really unpleasant for them. So sometimes they will actually describe their stomachs, the feeling of their stomach stretching. And sometimes we know that when children then go for investigations because perhaps they're getting recurrent pain, actually you can't find really any cause. And I think sometimes we can be quick to dismiss that when it's actually probably a really uncomfortable and unpleasant experience that they're having at every mealtime. And then the impact that the autonomic nervous system has, so that can actually, if you think about how we're then processing those feelings, that could be exaggerating that discomfort even more, and then actually making, if you're getting a really unpleasant feeling in your gut, there's the gut brain link and increasing stress, but then also the increase that stress has on the gut and inflammation. So these are all kind of complicated pathways, but you can just see this is just more and more load onto children who are already perhaps finding life quite difficult. And you get the sense that the systems just amplify each other and make things even more challenging. But then we can also, because the impact on the nervous system, have delayed stomach emptying, can have, like, perhaps for some children they're more easily feeling that nauseous feeling. Some children will get more reflux, again just probably because the nervous system is not quite doing what it should be in terms of controlling the gut digestive system. And I'm particularly interested actually in, and I can't find any data on this, but is there a link between hypermobility and ARFID, which is the avoidant restricted food intake disorder? Because if you're getting all of these like unpleasant feelings that's sort of magnified, actually you can really start to understand why eating could become quite a frightening experience. And so actually are some of the, we know there is a very strong sensory link with ARFID, and it's sensory based, but actually is it more complicated than that, and is actually the restricted eating is coming more from a fear of this discomfort? And then if you're having difficulty with your gut, we don't know, there might be differences in how micronutrients are absorbed, particularly if your gut is emptying more quickly than it should. That would mean you have less time for nutrients to be absorbed. So then you can have the risk that actually a child is undernourished, and that, of course, that then affects their capacity to cope with these extra demands that everything else is putting on them. So really important that we pay more attention, I think, to gut symptoms and actually recognize them early, because there can be very practical things that can be done to support and make some of these things easier. And then on to the next slide, please. So dysautonomia and POTS. So, and there's actually like another term that's now being used as well called autonomic instability. But dysautonomia is basically meaning that the autonomic nervous system is not functioning in the way that it should. And POTS, which is postural orthostatic tachycardia syndrome, is one sort of part of the umbrella term of dysautonomia. And this is something that, if I go back 12 years ago when I started working at Starjumpz, I didn't know anything about dysautonomia, but what I started to hear in the stories that I got from children, young people and their parents were repeated stories of feeling dizzy, particularly when moving from lying to sitting or sitting to standing. And I've seen this more and more. And now, because I guess I'm interested in it and I specifically ask about it, it's far more common than I'd ever appreciated. And it's also something that seems to, for many young people, get significantly worse at times of overwhelm, or particularly during burnout. What we don't know is it a precursor to burnout or a risk factor for burnout? It does seem to definitely get worse for some young people, a lot of young people in burnout, and it is also something that then young people seem to recover from, and the timing links to the timing that they're recovering from their burnout. So there's something going on there, and it's a very common symptom. It particularly is related to postural changes. And what we think happens is, if we think about the connective tissue, is almost like the sort of cling film around your body. When you stand, if it's not strong enough, it doesn't constrict those blood vessels and help them get the blood to your brain. So you get some pooling, and then the nervous system has a very intense reaction that's not helpful either in terms of increasing your heart rate. Because it does it too much. So then you actually get a quite inefficient system, and effectively what you're feeling is not getting enough oxygen to your brain. So some children will say that and young people will say that their vision is temporarily darkened or blurred, or they actually feel lightheaded or dizzy. Some may even faint or need to sit down. And the brain is very clever and gets you, you know, the worst case is that you faint, so it gets you flat so that the blood can then go to your brain. But it's a really unpleasant feeling, and for some people it's happening not just when they're moving around, and for some people it's happening, you know, many times in an hour. For other people it may be just when they've been sitting or lying for a while and then they have that change, but it can be really unpleasant, and so it's something that you're having to deal with, that feeling, but it's also something the body is having to work extra hard to then overcome. And if you add then in that from a sensory perspective, you might be far more sensitive to the feelings that you're getting. You can see again why this can all amplify. But there are other things that can happen with dysautonomia. So it can affect the way that your temperature regulation, your sleep-wake cycle, your digestion, your other aspects of sensation, so your taste. And I think that's very interesting again when we think about the children that we see in burnout, where for some their sleep-wake cycle is significantly disrupted. Their digestion is disrupted. Their palate changes. They want far more highly sugary or salty or fatty food, and it must all be linked, and because that also changes as they recover. And also managing all of this is actually very tiring. So it's another reason why I think young people get so fatigued. So then it's not surprised that there is that data that links chronic fatigue with hypermobility, particularly when we then add that to everything else that a young person, and particularly a neurodiverse young person, is dealing with day to day. And I think it really starts to explain some of the stories that we will hear from children who can't stand in assembly, who feel exhausted after they have a shower. So actually then the showering becomes too much. They struggle with PE. They're really fatigued by the afternoon at school and they can't concentrate. They feel overwhelmed and anxious in busy environments. And we hear these stories over and over, and sometimes we don't put the dots we don't join the dots and realize that, or look to see or wonder, is this child hypermobile, because this could explain all of these things. And it's really important that we recognize dysautonomia, because there are actually some practical things that you can do to help. Now, when I first started to recognize more and more symptoms of POTS, I would be recommending going for investigations. And I still think it is important that we exclude other cardiac causes. But some of the children that I see will go on to meet criteria for POTS, but often there'll be sort of the specialists that they've seen will say that, there's one piece of the jigsaw puzzle missing. They don't quite get the evidence, even though their symptoms can be really significant, and it can be quite frustrating. And sometimes they will wait for a long time to have the investigations and then maybe not get practical strategies. But actually simple things can make a difference. So actually just not going too quickly from sitting to standing, moving your legs first, doing some circular movements of your ankles to get the blood flowing. Compression stockings or tights or long socks for some people have been really helpful. Very important to make sure that your child or young person is drinking enough, because you often find that, again, linked to interoceptive difficulties, they may not have a very acute sense of thirst, and so can go for prolonged periods without drinking. It's often recommended to add salt. I think that you need to be really careful with that, because that can have added complications, but that is something that is often recommended. Gentle exercise. It's really difficult because actually if you're experiencing dysautonomia, exercise can be extra draining, but you're also these young people are often struggling with other aspects that will be impacting on their ability to exercise. So all of these things can you know, they may sound straightforward to put in place, but appreciate that they are actually very challenging. But there also are some medications that are used there. My experience, the feedback I've had from young people who've tried a specific medication to help, say with POTS syndrome, has been quite mixed, but some definitely have been helped by that. The other thing I think is important to mention in relation particularly to dysautonomia and POTS, but it is also relevant to the gut symptoms, is that many I do now ask about it, because I've learned that many families would actually not think it was relevant to report, and young people, because they would think, well, this is nothing to do with the questions I'm being asked about whether I could be autistic or ADHD or the other things I might be exploring. And so because it's a very physical, you know, because these are physical symptoms, sometimes it gets lost because people think, oh, well, you don't need to know about that because it's something else. So that's, you know, I always think no information is irrelevant, but that's just important to share. And then next slide, please. So if we just think back to our audit findings that I presented at the start, and in the hypermobile group, 34% of those children who are presenting to us for the first time for an assessment were showing signs of burnout versus 20% in the non-hypermobile group. What I have also found, my sense is that hypermobility is a particularly strong risk factor for burnout. And I was reminding myself of the study that Becky and I did in 2024, where we looked at 20 children who'd been out of school for 3 months or more, who we'd seen in clinic. So they were diagnosed with autism and or ADHD. And we looked back at their records to see, was there evidence that they were actually experiencing signs that we would now link to burnout. And we found that all of them were, and so we wrote that up, and that was presented at the International Congress of Psychiatry, and we had a very strong message to say we need to look beyond school avoidance, because the school avoidance is just one symptom of a much greater sort of collapse in functioning for these young people. But when I look back over that data, 80% of them were hypermobile, which is another reason why I am particularly interested in looking at this link, because we do need to find ways to prevent burnout, because once it happens, it's catastrophic and it takes so long to recover. And I do think that there are ways that we could prevent it, but we need to know what the risk factors are. So we actually have a student working with us from UCL at the moment who's going to be doing a 3-year research project to look at that in great detail, which is really exciting. It's so important. But it would make sense that it's a risk factor, because if we think about a young person's, I like to think of it's like their brain battery, and if you start the day at 100%, if you are autistic and or ADHD, before you've done anything extra, your day is already draining because of the extra work you're going to have to do to overcome executive functioning difficulties, to overcome sensory processing difficulties, and just sort of general kind of communication and social processing and emotional processing challenges. So you're already going to have your 100% is going to drain very quickly. If you then are hypermobile and you're experiencing pain, extra movement, fatigue, might be impacting your sleep, your digestion, you might have some dysautonomia symptoms, that's going to drain your battery even more, but has also probably reduced your capacity as well. And so if you then imagine that you are that child whose battery is already like really, like, you know, you're in the red zone, and then you have a fire drill, or you go into a lesson and it's not your usual teacher, or you're having to navigate the noisy lunch hall, and actually what you desperately need to increase your capacity to cope is to have some good nutrition, but you then can't eat because the noise of the hall is so overwhelming, or you have a fallout with a friend, you've got no reserve. So actually those things, for somebody who is not hypermobile but autistic and ADHD, they may have had that extra reserve to cope with. But if you have these, if you're hypermobile and you've got these extra challenges, how can you possibly deal with those unexpected things? And so then it starts, I think, to become more obvious why they will be more at risk of becoming overwhelmed and their batteries drained. But then it also is probably harder for them to recover day to day or over a weekend to go back into that same environment. So you see that cumulative drain on the battery as well. And so I think this is something that, and I know we've got a talk planned about burnout and prevention and introducing a sort of traffic light tool. But I think that we should be already just sort of flagging, and I'm trying to do that in my assessment reports and my clinical formulations to really help families and young people themselves, but particularly school, understand the added risks and just try to explain what this child is having to actually deal with day to day that is taking their energy. And then thinking about what can we do to reduce some of that demand. And some of it is not straightforward, and as much as we can make great recommendations, getting those in practice can be really challenging. But just as we think about all of these small things that are adding and culminating every day, a small change can make a significant difference, and small changes add up to have a bigger impact. So it's really important that the more we can understand about what the demands are on a child, the better the advice we can give. And actually, I think that has a much greater chance of having an impact, because we're recognizing all, and a lot of the things are things that aren't going to cost school money. It's not like a child needs significantly more support. They just need a different way of doing things. And I know that can be challenging because not everybody can understand that, but more and more I think we're raising awareness, and there is really good practice out there once people understand. And I think when you have something physical that you can use to explain some of these challenges with, it's actually much harder to ignore, and I think a little bit easier to understand. So really, really important that we can identify hypermobility. And next slide, please. So just thinking about those, and as I say, some of these are small things, but they can add to really make a significant difference. But the first is actually validating the child. So understanding so many adults who are hypermobile, and particularly if they are also neurodiverse, have horror stories about how they've had years and years of nobody making the connections and being, I don't know, sometimes sort of a sense that they've been made to feel like they're hypochondriac because nobody's made sense of all these different symptoms, and yet all the time there's been something linking. So I think it's really important that we understand and believe the child, because particularly when a child is getting physical symptoms and they might have investigations, and because they've gone to the hospital and there's been no cause found, we need to not be dismissive and say, oh, it's just because you're extra sensitive or you're anxious. Actually, we need to validate that that is really unpleasant for them and really challenging every day. How can we make that better rather than dismiss it? Because it's so difficult that so many of these symptoms are invisible, but they fluctuate. So, but we really need to trust what children are telling us and make sense of it. Adapting to environment, what changes can we make that could just make life a little bit easier for this child, particularly in school? But that could go, and as Olivia's talked about, but movement, seating, not waiting for children to recognize that they're thirsty and hungry, because they're probably not going to recognize that. So just making sure that they're prompted to drink, or always have that drink in front of them rather than wait for them to ask for it. Avoiding prolonged standing, particularly in hot weather, having quieter places to escape to in school, and that be something that's sort of freely available to everyone, so you don't have, you know, one of the things that can be so difficult is you don't want to stand out as different, and or be having to actually alert the teacher to the fact that you need one of these supports. So that needs to be really proactive. And then thinking about pacing. So for many of the children, they're not realizing when they're becoming overwhelmed and exhausted, and actually if you pile more on them, they're going to take it, and they're you know, so thinking about clubs after school and extra activities at weekend, and making sure that things are, you have built-in recovery time for children, not and not be sort of reassured by the fact that they're still looking like they've got energy. Just like thinking about, well, when has their rest been, and do I need to make some adjustments? Not necessarily doing less, but just pacing and building in that time for rest in between. Trying to help children understand the messages that their body is giving their brain. There can be, for some children, it's a very strong message which they then are struggling to interpret or are actually finding quite threatening. For others, it's not a strong message, but is there another way that they can actually read that message or interpret it, so that they're getting more of an understanding of what their body is trying to tell their brain about how they're feeling. So that's something that for some children they can learn, but if it's not going to come instinctively to them, so unless that's addressed, it's always going to be a risk factor into adulthood. So many adults who are hypermobile and neurodiverse, who have this sort of boom and bust life, which, you know, if they don't understand, can be really confusing and distressing, but they will push themselves and then not understand why they've then had, you know, they've had enforced rest. But if you can understand that that's part of you, and there's, you know, that's there might be things you could do to make that less extreme, but actually just understanding it can be some comfort. But actually also not, sometimes we can be a little dismissive when children are explaining some of the symptoms. So if they're really struggling to recognize a message they're getting from their body, we need to be careful not to dismiss that, because for them that's probably really significant. But we might say, you know, we might be quick to say, oh no, don't worry about that, or that's silly, or, you know, don't be so sensitive, when actually if we were curious about that, that would validate, but also maybe help them to develop a different regulation strategy, or avoid something that they know is making them feel like that. But I think we also need to really work together more, because increasingly I'm finding that the more at risk children in terms of getting overwhelmed and misunderstood have more complicated presentations, often where one parent may see a particular profile, a teacher might see a profile, the professional in clinic might see a different profile, and the risk is that then people will be thinking, well, somebody in that picture, that environment, has to be wrong, what they're seeing isn't correct, when actually we need to be joining up and realizing that everybody's correct, that's all relevant and valid evidence, but there is a reason for why you're seeing those different patterns, and just try to understand that more. So that is really important, and actually, as I said earlier, no piece of information is irrelevant. So for anybody who is coming for an assessment, don't worry about sharing any of this. The more you share with us, the better job we can do, because we've got more information to analyze and to explain. And this is something that I feel really is really important, and I think increasingly there's lots of services where you can go to have an autism assessment or an ADHD assessment. Nice guidance says that you need to have a physical examination, and there is particular mentions you need to be considering hypermobility. Doesn't have to be on the same day or with the same people, but you know, back in the day when I was first starting out in this work, which is now like 25 years ago, children would have had an initial assessment with a paediatrician that would have included a physical examination before they were then referred on or joined a pathway to have an autism or an ADHD assessment, and that could be with other professionals. But these things would have been looked at the time, and it's not just hypermobility that the physical examination is important for. There's lots of other things that we need to be considering and excluding, particularly for children who receive a diagnosis of autism. But increasingly, because of service pressures, we'll have different professionals undertaking those assessments, and so the physical examination bit can be easily missed, forgotten, and I think it is a crucial part of it. So if you're looking at providers, ask the question or think, is there a different way I can get that bit addressed? Because I think that is really important, and without knowing if your child is hypermobile or not, it will really impact the recommendations that are given. So I think you can some of these things it's the formulation that you have and the recommendations that you want to be, that are actually going to be helpful for your child, not just for a child who is autistic or ADHD or, if that makes sense. And then next slide. So this is just as a recap, the sort of important messages. The first is that hypermobility is more common in children, young people, people with neurodiversity, particularly autism and ADHD, and it should be actively looked for because of the added load that it brings. It's a whole body condition. It's not just bendy joints. We've underplayed it a lot. I can remember in my early career as paediatrician, people being quite dismissive of hypermobility, say, well, no, it's of no significance unless you had the stretchy skin and other significant symptoms that would have alerted you to the fact that this may be an Ehlers-Danlos syndrome profile. But it is far more significant than we have appreciated, and has an impact on the whole body. So pain systems, gut, brain, motor systems. So really important that we recognize that any of those physical differences or impacts of pain, energy levels, autonomic dysfunction leave you with less energy for learning and having fun and coping, and that, I feel, is a real risk factor for burnout. As I've said, physical examination matters, and that actually early recognition can really change outcomes. I think if you think about child's journey through school, so many things that they are expected to do that are going to be so much harder if they are also hypermobile as well as neurodiverse. So just thinking about the pen licenses and the impact that not, being the last in the class can have on your self-esteem. Whereas actually, if it had been identified early on that you're hypermobile and you're having some fine motor difficulties, would there have been a different way to manage that? And actually that could have then prevented some secondary harm. And that can happen in so many things, in terms of PE and assembly and school lunches and so many things that children are struggling with. It's just going to be even more of a challenge if you're hypermobile and neurodiverse. And then just finally, that it's just so important that we remember that we are wanting to understand and support the whole child, not just be focused on diagnoses. So thank you very much.
Thank you, Georgie. Let's just remove this. We've had a very interactive audience listening to this presentation. Thank you both so much. And many late diagnosed adults as well who are recognizing symptoms in themselves and expressing concern that things haven't changed for such a long time, which is, as you've covered, so important that it's picked up early and given the support that it needs. We've got lots of questions, so I'm going to start firing away some questions at you. So one of the questions was, can this lead to difficulties in later life, which you have covered. Some people are asking about if there can be links to osteoarthritis, issues with jaw problems, that kind of thing.
Yes, I mean, I guess, you know, anything that gives more movement and less stability to a joint is going to be putting it under more pressure. So that is you know, the wear, I think, as I said at the beginning with the house, the wear and tear is going to be more.
Yes.
I don't know if you find that.
Sorry, I interrupted.
If you had anything to say about that, Olivia, with what you see.
Yeah, I would agree with that.
I think you touched on Ehlers-Danlos and ARFID, that there potentially is links, but perhaps more at the moment looked at in adults. Don't know whether that's what you found, Georgie.
Well, I think ARFID is still such an emerging, you know, our understanding is still emerging with ARFID, and it's still like so many components to it that we're still starting to recognize. But I think that I haven't looked at my figures for ARFID and hypermobility, but that would be interesting to see if we're seeing that overrepresented.
And do the statistics for the incidence of hypermobility increase if someone has autism and ADHD? You may have already covered that in the cases that you looked at.
Yes, so there was, I can't remember the exact data, but I would say that what's difficult for us is that we see at Starjumpz, it's much more likely that you would be diagnosed with autism and ADHD because we're assessing everything. But I think also because of the population of children that we see coming for an independent assessment, often seem to be a little bit more complicated, or their presentation has not been straightforward, or they've not met referral criteria for another service. So, and those are the children are far more likely to have autism and ADHD because of the complex ways in which it can present. So I think our data would be a bit skewed anyway, because the majority of children that we see do have diagnosis of autism and ADHD together.
Yeah. Somebody's commented that their son's, I'm not sure if I'm pronouncing this right, Baton scale. Don't know if you know that. Went from 6 to 4. The child has been diagnosed with dyspraxia and autism, but it still looks like they have hypermobility and complaints of pain. So sounds like.
Yeah, so I think there are challenges with the Baton scale, because it does, there is a little bit of subjectivity in terms of, you're supposed to be looking for particular angles, but what you see can be and what you agree on could be different between clinicians. But also, as you get older, it's natural and normal to be less flexible, which is why the diagnostic kind of score changes from prepubertal and then as you get older. But it is also, when you're assessing adults, that you ask about historic, could you do this when you were younger? And that's significant, because it's recognized that for some people that will change significantly. But it's also interesting in that in research, they'll often use a Baton score of 1, because actually if you've got evidence of one joint being hypermobile, you are, I suppose, technically hypermobile, so you would be included. So they have to have a binary, it's yes or no, whereas clinically it's not as straightforward as that.
I think it would also be important to find out if that child has had intervention, because possibly the positive aspects of intervention could positively improve their scores.
Yes, absolutely.
Bring in the necessary intervention strategies.
Yeah, and also important to know that there isn't a clear correlation between the Baton score and severity. So yes, you could have a child who is remarkably hypermobile, but actually that child could be functioning kind of in a healthy, robust way. They've still got, I would sort of be cautioning that there are risks, but I do see children who I'm surprised at how hypermobile they are, but actually they may be at that stage when I see them in all other aspects coping, and another child who's perhaps less hypermobile but has got all of these other added, it's having a much greater impact.
Interesting. I think you have covered that children with sensory processing issues and pathological demand avoidance can have a tendency towards presenting with hypermobility. Is that right?
So sorry, what was the...
So children with sensory processing issues and or pathological demand avoidance are often likely to have hypermobility associated.
Yeah, so I think, you know, the evidence would suggest that so those associations are still considered neurodiversity, and so there is a link with any neurodiversity. It's just particularly prevalent in the autistic ADHD population, but sensory, I think it's sort of, there's so much overlap, and actually sometimes the PDA profile, it might be that actually that's not fully pathological demand avoidance, but more an extreme intolerance of demands because you don't have the capacity to say yes to that demand. So they can be, what you see might look the same, but what's actually driving that might be quite different.
Yeah, so getting to the root cause of what's driving it is so important. To know how
and I would say that some of the children who are most significantly impaired in terms of they're not functioning will have the whole combination that autistic, ADHD, dyspraxic, marked sensory processing and interoceptive awareness difficulties, intolerant of demands, but it's more for some of those young people, there may be PDA and that's kind of been a risk factor to their overwhelm. Or it may be that actually they're just because they can't function, they have to say no to everything, or they can't do those things. So that's a little bit complicated, but then also hypermobile and dyspraxic. I don't know if I've mentioned dyspraxic, because they're all things, if you think about, they're all things that just add to make life more complicated.
Yeah, completely. So this question, maybe Olivia, you could start to answer this one. Do children with hypermobility often get diagnosed with dyspraxia? We've just touched on that, or apraxia. And can the motor challenges be entirely down to hypermobility?
I wouldn't say that hypermobility causes dyspraxia, but there is definitely a link in avoidance of doing motor tasks because there's often increased fatigue or not well managing how much they put into the movement, which could lead to coordination difficulties and dyspraxia. So I wouldn't say it's a cause, but it definitely impacts a child, and they can happen concurrently or separately.
Do you want to add anything to that, Georgie?
Yes, so I think, you know, it can be tricky to work out. So for me, from my role in assessing for dyspraxia is I will have the motor assessment scores from occupational therapists and their observations, so that have shown that there is a motor difficulty that falls below a particular standardized level. And so you can see that you've got the evidence of the impact on motor function, but you've then got to decide, is there a neurological reason for that or another reason? And sometimes when you have a child who is really very hypermobile, it can get a bit confusing, and you'd be thinking, well, actually, is that difficulty sort of explained by the hypermobility? But there are usually other features, particularly around coordination, that just wouldn't be explained. And also I feel that if your hypermobility was significant enough to be responsible, but it's contributing so much to your motor challenges, you would have other symptoms as well. So it's just sometimes just teasing it apart. But I'd have more children that are both hypermobile and dyspraxic than
Yeah.
We've thought
And
that they can't be dyspraxic because they're so hypermobile, if that makes sense.
yes. And dyspraxia is also known as developmental coordination disorder, for any of you that know that term. So somebody has just made a comment that they were diagnosed with autism and ADHD and Ehlers-Danlos in their late 30s, but have accumulated many physical and mental health issues as a result of it not being recognised and supported. Somebody's made a comment asking about jaw issues and osteoarthritis. I think you've touched on that already. Someone here again is talking about late diagnosis of dysautonomia at 36 and ADHD at 40, with an autism diagnosis being awaited. This person was told on 2 occasions by different consultants that they were hypermobile, but this was dismissed more than it being treated seriously as a diagnosis. And this person said they didn't get any support or help from the NHS and felt almost like they were being gaslighted for talking about the difficulties they were having, which is...
Yes, and those are stories that I've certainly come across many times. And I think, you know, when we think about the missed generations, you know, there's an explosion in adult diagnoses that, you know, some people are suspicious of, but as my view of that is that they are all children that we've missed. And I think we can understand how we've missed them because of kind of criteria that were very rigid, of not actually even assessing children who presented differently at home versus school. So, and these are all genuine cases that we've missed. And that is the scandal, really, isn't it? So we need to, and we're not actually, I don't think even, we're very far from improving that in paediatrics. So there will still be children that we're missing now, even though we're recognizing more and more the fact that that is an issue because of so many adults who are being diagnosed later in life. But I do think that we should be thinking of how can we prevent, because there's so much secondary harm. I don't think there would be anybody, I mean, there might be, but my experience is that people who have a diagnosis in adulthood have a whole story behind them of how they have struggled, and things have been really, you know, misunderstood, disadvantaged, you know, amazing people, but that have somehow, and many of them have overcome so many of those things, but actually very painful for most people who have had that experience of being diagnosed late in life. And we need ways that we can be better at working all of this out. And actually, if we've established that there's such a strong link between hypermobility and autism and ADHD, should we be assessing everybody who's hypermobile for autism and ADHD? Clearly, you can be hypermobile and not be autistic ADHD, but that would, it's something that's fairly easy to look for physically. You know, it's going to take a few minutes versus a few hours, and maybe that's what we should be doing, is screening children for hypermobility and then looking, because then we would, but then it's that whole kind of dilemma of people kind of not wanting to label, and you know, but when you can see the harm that your needs being missed causes, it's really important. But I also think we do need to be looking at our autistic ADHD children for hypermobility because of the extra risks it brings and the extra advice that we could give, particularly to school, but also to parents if they're not, you know, so many parents have already worked this all out and they know exactly what adjustments they need to make for their child at home to manage the demands of school. But sometimes that can be misunderstood, and they then if schools are not understanding that. So actually we need to be validating that more, because if they weren't doing that, the risks would be higher. But some families don't understand that, and they're sort of at the infancy of their understanding of neurodiversity and the impact it has. And so actually they might be thinking that they're doing the very best by having these extra things that their child is doing after school, when actually that child just needs to come home and have a rest before, it might be they could still do that, but they just need to do it in a slightly different way.
Yeah, absolutely.
I also think that the type of activities that we recommend are quite important. Rhythmical things like swimming and cycling and Pilates are way more helpful and on the joints than, for instance, running. But I think there needs to be a balance between doing the sport, because the muscles need to develop and support the joints, as well as making sure there is a sufficient rest time.
And also a number of girls that I've seen where they've had repeated injuries due to sort of overstretching because they've been doing gymnastics in school or other sports, and actually when they've been alerting the PE teacher to that, they've been dismissed, and it's a real, it's a risk, and then the pain and the recovery from that, and they've been, they're not allowed to take time off, that if their hypermobility had been recognized and appropriate advice given, that could have been prevented.
We've had a teacher who's at the start of their teaching career who's made a comment that it would be great for schools teachers to be aware of this and for there to be more understanding and support. And I have said in the comments that we can provide training for schools, and it's something, we're keen to raise awareness in the educational world. We have a question about an 18-year-old who doesn't understand or is having difficulties with interoception. For example, doesn't know when he's hungry until he's absolutely starving, or when his bladder is full, or muscles fatigue until he's burnt out. And so they're asking, is there some sort of general advice you could give for this, for how we would help at Starjumpz, or how OT or a paediatrician might help?
I think I can answer that. So we would do an in-depth interoceptive awareness interview with the clients in order to find out which areas are a struggle. There may be numerous areas, and also have the young person do a self-assessment compared to a caregiver's assessment, so that we can see, is there a match or possibly a mismatch between what the child or the client is feeling and reporting compared to what is actually happening, or what other people are seeing. And then to begin intervention, we would look at learning how to understand body signals, doing all sorts of experiments, learning the ways in which the body responds and how they feel, and experiencing it in person through various activities on why your body presents or responds in a certain way, and then what can be then looked at that would increase regulation and improve overall awareness and understanding of how the body's responding to be appropriate to that incoming signal.
Thank you. Anything you want to add, Georgie?
Yes, and I think also then sort of talking more about feelings and name it, this is more for when we've identified this in a younger child, is that sort of modeling of and just sort of increasing awareness, but also looking at different ways of being able to recognize and going and actually at the same time minimizing the risk that going for hours without a drink has, by putting in routines. And for many people, actually it's sort of something you have to do in parallel, and that actually you can just having good routines that you stick to can really reduce risk, particularly around nutrition and fluids.
Thank you. Somebody's asked about a 14-year-old who has ADHD, autism, and global developmental delay, and who has hypermobility, who has very high anxiety. But paediatrician has said they don't prescribe medication for anxiety. I don't know if you can comment on that, Georgie.
Yes, I think this is there's again a gap, because I guess most young people of that age with anxiety would typically be seen by CAMHS, or Children and Young People's Mental Health team, and sometimes you're restricted from that service if you have a diagnosis of autism or if you have a learning disability. So there are some places that have specific ASD like teams or learning impaired teams, but there are gaps that people fall in. I would say that for some young people, medication for anxiety can help, but what is actually really important is that all the triggers for the anxiety are looked at, because they're likely to be things that can be avoided or mitigated against. It's complicated, but I mean, certainly I actually have got many learning disabled young people who are on treatment for anxiety, and we do think it's helped, and that their families think it's helped, but it's not straightforward.
Thank you. Somebody's asked, are there more clinically recognised descriptions for things like brain fog? Because they feel clinicians don't always recognise this. I don't know if you have any comment on that.
No, and I think that it's difficult, isn't it? And we're only just starting to recognise it as an association with hypermobility. And I would say that, typically if you're thinking about brain fog, you'd be thinking more about ADHD, and sometimes it can be difficult to distinguish. But I suppose it's thinking about all the other symptoms that you might be having alongside that.
The person has also commented on the effect of menopause on brain fog.
Yeah, absolutely.
Do you know if there have been any studies on hypermobility and the vagal response to nausea and stress?
No, but obviously vagus nerve there's a lot of work now looking at vagus nerve and role in sort of resetting nervous system, and what we're finding in a lot of the children that we're seeing in burnout is there's very much a sense that they are stuck in fight flight. And if we've got a child who's hypermobile, I think the risk of that fight flight response, from what we're learning about the way that the autonomic nervous system is working slightly differently and the interoception, I think there is a risk that you're more likely to be in fight flight when you're hypermobile. Not obviously all the time, but it links back to this change in the amygdala, and the fact that for some people means that they can go into an environment like school, which wouldn't be threatening to another child, but actually their brain is perceiving that as threat, and our threat response is fight flight. But if you've also there's a difficulty in regulating your heart rate depending on your posture, you're going to be getting another feedback where if your heart rate increases, your brain sees that as a sign of, I need to get ready to fight or fly, because that is a sign of danger. So we've got these different sort of ways that it's all, I think, compounding and risking that we're become more stuck in the fight flight. And to reset and get more into the parasympathetic nervous system, so the rest and digest, you need there is evidence that will show that if you can activate the vagus nerve, stimulate the vagus nerve, you can do that. So I think it is all linked. It's just how you do that, because for many people in this position, they can't deal with the demands. They don't have the capacity to do that. So actually any of the exercises that we would perhaps be suggesting, they need repetition, they need to be consistent, and it can be really difficult to access because it is a demand. But there are lots of things like different breathing exercises, different movements, listening to certain types of music that can help with resetting the vagus nerve. And I think it is a really, and of course the other is the technology that we have in terms of vagus nerve stimulators, that it's a very interesting and exciting area. And I do think that for many people it can work, and I've got anecdotal evidence of that, but it's not straightforward because all these things have added challenges. So even we think about the alpha stim that we use at Starjumpz, that can be great for some people, but actually you've got to be able to tolerate having the gel on your ears and something attached to your ears, and if you're completely overwhelmed from a sensory perspective, that just might be too much.
So somebody has said thank you during the presentation, that they're starting to see a link through the whole family all the way back to their grandmother, and that they're being treated
really
for Ehlers-Danlos, and then the person that's commented is waiting for a diagnosis themselves and has been told they're just double jointed and bendy. They also have IBS, anxiety, and they've had difficulties with pregnancies resulting in C-sections, brain fog, clicking joints. So a lot of difficulties that haven't been recognised from an early stage that obviously seem to be running through.
And I should have said actually that there are some really good organisations that can help. And I just want that. So there's an Ehlers-Danlos UK organisation. But there is one also for children with hypermobility, and I'm just going to see if I can tell you what it is. So keep talking and I'm going to find it.
Somebody's mentioned at the research All Brains Belong. I don't know if you've heard of the research, Dr. Melissa Hauser, which talks about different systems being connected, which I was just having a quick look up while you were presenting. That looks interesting.
I've not come across that. No, so the organisation is hypermobility.org, and then it has and then it's /kids KIDZ-zone. So I think that is good.
Hypermobility.org /, did you say?
/KIDZ-zone, and that's got a lot of practical suggestions and help.
Thank you.
So, and then the Ehlers-Danlos UK.
Great.
Sorry, Jo, I have to go. I'm so sorry.
Thank you, Olivia. Are you okay to do a couple more, Georgie, or do you?
Yes, yeah.
Okay, thank you. Thanks, Olivia.
Thanks, Olivia.
Bye.
Somebody's mentioned that they home educate because of SEND children not getting the help they need, which I know we're seeing a lot of home educated children.
Yeah, absolutely.
Somebody says they wish there was this awareness when they were a child at school. Could have made a lifetime's worth of difference, but it's good we're getting there gradually. And thank you for taking this further and presenting your findings. And then another person talks about having autism, ADHD, benign hypermobility syndrome, fibromyalgia, other bladder and bowel issues, and a lifetime of anxiety and depression. Only diagnosed with autism and ADHD recently at 56. All their children are hypermobile with autism and ADHD, and nobody saw the link until now, unfortunately. And there's quite a few comments saying they've experienced the same. Somebody said they were just told they had growing pains.
Oh dear.
Yeah. And were told in their teenage years it was all in their head. Somebody mentions that their son has PDA and avoids prompts for eating and drinking, and so that can be difficult. Somebody says, I think you touched on it earlier, have these neurodiverse conditions always been around, or are cases increasing due to things like being on screens more?
I think that they've always been around, but I think that, and you know, clearly we've missed so many because of adults now being diagnosed late in life. But I think that the impact is more now for lots of different reasons. But I think society's changed. You know, there's social media, I'm sure, has an impact. Screens, changes in school. We're, you know, 24-hour, 7-day-a-week society. Impact on family, church, you know, lots of changes that maybe made it a little bit easier to manage, or it would have been easier to put strategies in place, and probably that's how people did manage. Not, you know, clearly lots of people that are receiving diagnosis in adulthood weren't coping, but maybe actually if they were children now, it would, the impact would have been so much more significant. So I think I think we're also more aware, I guess, and it's, so some of the children that we see now, that where it's, their presentation is very complicated, but we understand that, and we can pull out all the evidence and show how they meet criteria and be confident of our conclusion. Maybe 15 years ago, they probably wouldn't have been identified as an assessment because somebody would have thought that's not consistent enough evidence. So I think there's lots of different impacts.
Yeah, absolutely. Again, someone in their 40s said they haven't had any support and not a holistic view of what they were experiencing, including, you know, being gaslit, and said that as a result, you know, they've experienced quite a lot of trauma, which is just, yeah, very sad. But hopefully more awareness is coming. Somebody is asking about the link between hypermobility and developmental coordination disorder. I think we've already touched on that. But they've asked, can children be misdiagnosed with developmental coordination disorder?
Yeah, I mean, it's possible. You know, you should, when if you've got the evidence there and you can clearly see the impact and there's no other reason, then that's obviously there, all those criteria there to avoid misdiagnosis. But actually it can be very complicated, particularly when you've got so many other things impacting.
And somebody's asking, who should they ask to be referred to check for hypermobility? So
there are different routes. I mean, so your GP should be able to assess for hypermobility, a physiotherapist or an occupational therapist, paediatrician. So you could, it would really depend on the impact, but typically, you know, if I see a child in an assessment and I've identified that they're hypermobile, if they were experiencing significant pain or other symptoms, I would signpost them on. So if it was pain, I might signpost them to a paediatric rheumatologist, or certainly recommend that. It may not be possible for them to access that, but or I might, if it's more fine motor difficulties and interoception, occupational therapy, or gastroenterologist, or it might be a combination of lots of things, or put in play, or sort of recommend that if this happens in the future, this is where I would recommend that you go. But obviously, it's the services are patchy, and not so often to get to see a pediatric rheumatologist. You have to see a paediatrician, a hospital paediatrician first. So if that paediatrician doesn't feel that your symptoms are significant enough to warrant the referral to the paediatric rheumatologist, that's going to be something that's not going to be possible.
Okay, so if somebody had a diagnosis of autism and ADHD, could they come and have a consultation with you to look at hypermobility if that's something that hasn't
Yeah,
been...
so we do that quite a lot, where maybe a child has had different assessments with different providers, and so it's quite common that families may have, you know, 3 or 4 different diagnostic reports, all of which have got their own set of recommendations. What you actually need is one looking at everything to give that sort of, because sometimes, particularly if your child is autistic, ADHD, some of the recommendations that maybe are in your autism report may not be necessarily that helpful for supporting their ADHD needs. So I think it can be quite helpful to have that overview, and just be looking at, because a child's needs change over time and they develop over time, actually just sometimes having a not a full reassessment diagnostically wise, but just a sort of update on their functioning and what the specific challenges are now and what would the recommendations be, to help with those, can be quite helpful. And we do that a lot.
Yeah, thank you. Somebody's asking for secondary and college age. What sort of person should they see if they want to get support from college or secondary school?
So I suppose if it's from the medical side of things, having challenges identified, it would probably be GP, and then an adult. It depends on their age, but an adult autism assessment or ADHD, in a lot of places that are doing, and now sort of a lot of places will do right to choose, and you can have both assessments at the same time, which can be, it's obviously recommended. In terms of the support then in college, it would be through their learning support team. There are adult specialists so adult physicians that specialize in hypermobility. I think probably, obviously to access that NHS, you'd need a GP referral. I think there are sometimes you can get to see them through a physiotherapist. There are private adult specialists, possibly easier to access privately. So there are different routes, but probably GP is a good start point.
Thank you. Somebody's also commenting on their child who's been through various diagnoses and now suffering with burnout and chronic migraine, persistent headaches, who's saying they wish they found the link earlier and they may have been able to avoid reaching burnout stage. I know you're going to be doing a talk in July, coming up soon, on risk factors for burnout, which could be of interest, which will help with looking at burnout and preventing burnout. What are the things that one needs to look out for?
Yes.
To see if I can quickly get to the last. How do you assess functionality when families choose alternative lifestyles? For example, child-led home education. I think you do see quite a lot of children who are home educated, so that's something you're familiar with.
Yes, and obviously it's finding out the journey to that, because for many people, I would say for me, it's more the families I see, the more common scenario would be not that it's been a lifestyle choice, it's been because they've had to do that because their child has not coped in school and they've not been able to get the support that child has needed in school. Or it could be that they have, and actually we have children who are who get a special school place that actually can't, that environment is still not right for them, and actually the only option is being at home, and that's where they do best. But so it would be kind of trying to find the backstory to that, but then you'd still do all the same. So assessments are not dependent on a child's like school level or learning level. Some things are a little bit more complicated if you are learning impaired, but there's ways around that. So I don't know if that's what the question is sort of alluding to, but
I think you finding out about their function would be through what's happening at home and from
and
your
again, I think when
information
it's
from the child and the family, yeah.
Yeah, and the children are coming to see us for a reason, and it's usually because there is a concern somewhere that something is harder than it should be, or it's expected to be. So I think I wouldn't sort of see a child where it's a lifestyle choice to be having a child-led education. But my concern would be where that has been the only option because of the way that child's nervous system is functioning in this environment.
Somebody's saying that clinicians are now saying ADHD medication helps anxiety and helps with emotional regulation. Would you agree with that?
Yeah, so definitely with emotional regulation. It's interesting with anxiety because actually anxiety is a sort of contraindication to ADHD medication. But as I always say when I'm explaining that to people when I'm talking about medication, if I couldn't prescribe ADHD medication to anyone who had a history of anxiety or anyone in their family who had anxiety, I probably wouldn't be able to prescribe it to anybody because it's such a common link. But you do have to be careful, and that some medications can it's very individual, but some people do find that medication makes them feel more anxious. But I've probably got more young people where their anxiety has fallen away, and that's usually because they're then able to think, that what happens with ADHD is a lot of catastrophizing and not being able to switch off thoughts and them all getting a bit carried away, and that sort of accumulates to more and more of an anxious feeling, and so actually if the medication works for you and you get some clarity in your thoughts, it can be much easier to rationalize some of those fears or worries. So there'd be a significant proportion where I'd absolutely agree that it helps with anxiety, but it very much depends on individual basis.
Yeah, somebody's asking about you talked about fight and flight as a stress response. Do you also see fawn and collapse?
Yes, and shut down.
Yeah, shut down. Yeah, absolutely. And can polyvagal theory and awareness be helpful to get a better regulated state?
Yes, and actually more and more I'm recognize the importance of that, because sometimes you can be seeming like everybody is doing everything they can possibly think of to support a child who's in burnout, including sometimes medication, and actually you feel like you've got stuck and you're not seeing any movement. And for what we're recognizing more and more is that actually probably what is the barrier there is unresolved trauma, and recognizing more that children often in these situations, just the experience of school, and particularly if we think about thinking about how hypermobility must be impacting on some children in their school experience, when you think about everything it could be doing to gut, brain, heart, joints, it's traumatizing, and it's the way that also they're processing that emotion. It can be traumatizing. So and that can be really hidden, and it's not because somebody in school is actively trying to harm that child, it's just the environment, people not understanding, and then actually the child not realizing because of their interoception signals that they are in an environment that is actually really, their brain is saying is really threatening, but they can't get out of it. So but then to try and resolve trauma with the ways that we kind of know can work takes a lot of brain power, and the child is not in that position where they've got that. So I think increasingly, and I have some people, but again this is just complicated, and as I said, because it's demands, but if we could find a way that is accessible for the child to engage in that can reset the vagus, then I think there is definitely room for that. You know, that I can understand that that could be helpful and not cause harm. That's the most important thing as well.
Definitely. Okay, last question. So someone has commented that the expectations and stress in the education system has increased in recent years since 2019, COVID, and the after effects of that. And I think we've definitely seen that as Starjumpz in the complexity of cases and the burnout and the children being homeschooled. The same person has commented that parents are experiencing accusations of fabricating illness. And the last question is how can they get over those fears and experiences as parents?
And it's really distressing and difficult. And I have been doing some work with some organisations that are supporting and really trying to raise awareness about this. And there are, I mean, if they want, if we can signpost them, then, you know, contact info, because I can certainly share details, because there are huge groups of people that have had similar experiences. And I think it's just really important to get people, you know, if you can get people in your team, other professionals, therapists that can really try to understand what is going on for your child and advocate on your behalf. Yeah, but I do really, you know, we've had some very horrible, distressing experiences with families we're supporting at Starjumpz, but I'd hope that there is gradually more awareness and that this is not going to happen as much as it has been.
Yes, absolutely. I've asked for that person, please email us info@Starjumpz, and we can signpost you to some of those organisations that Georgie's working with. And yeah, I have to thank everybody for such brilliant questions and for your comments to each other as well. And thank you, Georgie and Olivia, who's had to leave us. But thank you so much for your presentation and for answering all those questions. It's really fabulous to learn so much more about hypermobility and how it links with neurodiversity. I don't know if there's anything final you want to add or say, Georgie.
No, but I think, you know, great to have the opportunity to raise awareness about this. So thank you. And I look forward to speaking about burnout, and hopefully have got the next version of the burnout traffic light tool that I'm hoping will be helpful for families to just look at ways that we might be able to prevent some of this from happening.
Yes, and if you'd like to contact info@starjumpz.com if you'd like to book an appointment with Georgie or an assessment, please do so. And you'll be able to find this up on our YouTube channel as well once it disappears from our Facebook channel. But thank you all for joining us this evening. Good night.
Thank you. Bye-bye.